So the topic we were asked to talk about is the challenges for health policy in India in 20 minutes. That's a very big challenge in and of itself. So I thought it would be, this is a nice friendly group, so I thought it would be interesting to kind of really take a risk, not present you with a lot of numbers and charts and figures and so on, but actually opinions, depending on how much confidence you have in Ajay's kind introduction, opinions based on some experience in India, and think about what we can learn from a decade of investment under the National Health Mission for health policy for the future. So I'm going to do a little bit of background, and then I want to look specifically at what was happening with NHM. I'm going to take a risk and give some grades to different aspects of what NHM was intended to accomplish. You can decide whether you think I'm a tough grader or a gentle grader, and then I'll talk about what the implications might be from looking at this report card. So let's start in 2005. I was here with the World Bank in India when the government announced the National Rural Health Mission. This was preceded by speeches by the finance minister and the prime minister, both of whom announced that the government would increase government health spending from at that point slightly below 1% of GDP to somewhere between 2 and 3% of GDP by 2012. Now, when the health minister says we're going to increase health spending double or triple as a percent of GDP, you don't pay any attention to it because it just sounds like dreaming. But when the finance minister and the prime minister say it, maybe you think there might be some evidence behind it. So there was a very buoyant economy and very high expectations for a continued buoyant economy. The government that came in 2005 had a strong political mandate and a strong commitment to new domestic initiatives in social development, including health and education. And also, India had signed on to the Millennium Development Goals. So there was a clear set of global goals to invest in. It wasn't just anything, everything, pie in the sky. There were very specific things to achieve in terms of child health, in terms of maternal health, in terms of priority disease control, and child nutrition. So this was a moment when it seemed that it was clear what could be done and what would be done. What was in the program? Well, actually, if I look back on this, I actually think the National Rural Health Mission, or what became the National Health Mission, was a reasonably well-conceived program in terms of its overall design. So let's just go through some of the key elements that I'm going to then try to review subsequently. For financing, there was a very ambitious goal, the 2 to 3% of GDP by 2012, but there were very specific objectives of what was going to happen. There were specific percentage increases in central funding and concomitant percentage increases in state funding that were laid out at that time, which were to happen year on year. So this seemed to be based on at least some concrete targets. There was a plan for being able to accelerate the capacity to spend money and to improve financial management. Things like the expanded use of health societies, the use of untied grants, which would just be given down to district, block, and even facility and community level, and the conditional cash transfers that were being developed for women to deliver babies in health facilities. There was an effort to improve equity with a focus of expenditures on what were called the EAG, Empowered Action Group. I never knew what that meant, actually, Empowered Action Group states, which was supposed to help reduce the disparities in spending across the states. There were clear intervention priorities. Maternal, newborn, and child health and disease control were really the clear focus of the National Rural Health Mission. There were new service delivery strategies. There was a massive program of district planning that was launched and put in place. Every district was to develop an annual plan, which had to be reviewed and approved to trigger this funding. There was the development of the ASHA, a new generation of community health workers that would help with the implementation. And there was something called the Indian Public Health Standards, which were put forward. These were very specific standards of inputs that would be met by health facilities. numbers of staff, types of staff, supplies, and other things. And there was a baseline created of what was already out there, so this would become a target for future investment. There were new management strategies. So in the NRHM plan, there was budget made available to hire management consultants at district level and at state level. The societies were staffed by professional managers, and the districts also were able to hire professional managers. Not very high-level managers, but not just being run by doctors or the surgeon in the hospital or whatever. And there was a community engagement strategy to create village health and sanitation committees. So overall, if you look at all of this, this was a fairly sophisticated, well thought out program to transform public sector health delivery in rural areas initially. There's also an urban health mission now, but in rural areas initially, that I think had a lot of sense to it in terms of what was actually intended. So the money was promised, the political commitment was there, and there was a program, a substantial program. And I think we should acknowledge that this was really quite a watershed moment in attempts to improve health in India. There were also some important changes. Child mortality has been improving quite significantly. Maternal mortality has been going down. Polio was eliminated in India during this time. But it's important to note that these outcomes, which were prioritized for the National Rural Health Mission, were already trending downwards prior to the program being developed. And it was very difficult, it is still very difficult, really to try to attribute impact to the program. And this is, I think, one of the real missed opportunities around the National Health Mission is the opportunity to actually evaluate what works or what doesn't work, and also the rollout of the program created opportunities for evaluation which were largely not taken advantage of. But I do think that one would be hard-pressed, at least in many states, to argue that the National Rural Health Mission did not contribute to these positive changes. I think it sort of, you know, in a sense of, there's a concept in evaluation called adequacy, which is that if you see the indicators you think ought to be moving in a certain direction, moving in that direction, and you're doing things to support them, at least it's plausible that these things are having some benefit, if not an entirely attributable benefit. So now to my report card. So I just took these different elements of the strategy and I said, well, what do I think we actually could say about how well we did, or how well the program did in this ensuing 10 years of implementation? So just quickly, this is my completely subjective, absent data that I won't present you. There is some data, but I won't present any of it. Outsider's view of what occurred over the ensuing decade. So in terms of financing, of course, nothing like the goal of 2 to 3% of GDP was attained. Financing went up from slightly below 1% of GDP to about 1.1% of GDP. And
which one is good?
1 is low, 5 is good. Sorry, yes, my scoring system. So I gave no 5s. I didn't give any 1s either. Maybe I should have. But so in terms of financing, nothing like the goal that was set was attained. There were significant increases in expenditures for both central sources and state sources. But I think it's clear that the ambitious goal that was set was nowhere near attainable given the instruments that were available. And in fact, while things started off very quickly in 2009 with the global economic crisis, they slowed down quite dramatically. What we see happening in NRHM, NHM expenditures is that the amount of money that could be allocated initially was not being spent very effectively, and that then less money was allocated in subsequent years, so that eventually the allocated amounts and the spent amounts started to converge, but at a lower level than was anticipated. States also allocated more money, but not nearly as much as was needed to try to achieve these goals. Think about the fact that India, the public sector in India is about 70% state financed, and so an increase of doubling or tripling as a percent of GDP, which is extremely ambitious when GDP is growing at 8% a year, requires the states to dramatically increase their expenditures, much more than the center, to achieve this goal, and that was not happening. Expenditure acceleration measures, well, I give them a sort of a middle grade. The society instrument was widely created. It works. First of all, let me say, any grading on an all-India basis really disguises a lot of differences across India. So these are averages. The societies seem to work well in some states. They actually do receive the funds. They do disperse the funds. And in some states, they actually disperse more funds than they're initially allocated and get supplementary budgets either from center or state sources. But in other states, they didn't work well at all, and there were large shortfalls between what was allocated to the societies and what was actually spent. Unfortunately, these shortfalls tend to cluster in the weaker, poorer states, the states with the greatest need. And also they are disguised by the fact that society-level funding could be rolled over from one fiscal year to the next. And so the balances available to the societies actually are much greater than the amounts that appear in the annual allocations to those societies. So in some work we just completed in UP, the society seems to spend about 70–80% of the allocated funds on an annual basis, but in the most recent years it's more like 40% of the funds that are available. So, and this problem with the differentials in ability to spend money in the analysis that we've been doing recently suggests that the disparities in spending between the better off and the worse off states actually got worse during the NHM period, even though the program was targeting the worse off states for special attention. This is because the better off states can mobilize more of their own money, and they spend their own money and the center's money more effectively than the worse off states. So an average score overall, but a lot of difference in different states. Equity, the EAG states, again, more money went to these states, but not enough, not nearly enough to close the gap between the better off and the worse off states. And so there's a lesson here that perhaps central funding is not really a sufficient instrument to accomplish this. Intervention priorities, yes, NRHM focused on its stated priorities, and I think plausibly contributed to the progress that we see in those. Service delivery strategies, well, there was a substantial attempt to strengthen the public delivery system, so I think those parts of the NHM program did function, but again, a lot of difference between the better off and the worse off states. And so we see, again, not only disparities in spending, but we see increasing disparities in access and use of services and so on. Management strategies, a very mixed bag. Consultants were hired, they were placed in the districts, they were placed in the state societies, but the reports that came out of the work with these consultants were not very positive. Many of the consultants felt that they were not being used for significant technical tasks. They were basically office assistants to the local administrators and officials, and that this didn't really accomplish what it was intended to accomplish. And community engagement strategies, a lot was said about communitization. Not really that much was done. There were a few demonstration areas, but it certainly did not have a widespread transformation on the engagement between health services and communities. So a pretty mixed bag from this 10 years of implementation. So to come to, and then I think there's a second aspect that bears some attention, and that's what I would refer to as both complementary and competing developments. So in this decade, when NRHM and NHM were being implemented, there were a number of very significant, I think, competing health system developments from the side of the government. The government launched a health insurance scheme, which was targeted to the BPL population. This was being run from the Department of Labor. So whatever resources might be available from central sources were now being used through two major national centrally funded schemes, the RSBY health insurance scheme and the NHM through the Ministry of Health. States, a number of states, especially in the southern states, launched their own state health insurance schemes, and we can see in these states the competition over resources as money flowed into state insurance schemes for hospitalization, and state funding for primary care or basic health services tended to flatten out or not increase at the same rate. So there was competition for resources within the government. ICDS remained a separate scheme in nutrition under the Ministry of Women and Child, and this also competes in some ways for resources for basic health care. And a rapid growth in the private health sector also created alternative pressures on health, especially in the southern states, which are much better resourced in terms of human resources for health in the private sector. And then there were other initiatives in the government which perhaps were complementary, like poverty alleviation programs like NREGA, and also now the implementation of the Universal ID Scheme, ADAR, which provides some mechanisms now for making cash transfers and expenditures more efficient. So it's not a stable situation. A lot of things are changing. But overall, I think the sense of what happened during this 10 years was that an early, highly ambitious and politically supported initiative tended to kind of lose momentum and give way to more competing schemes that drew away resources and attention. So, coming to my topic here, so what can we learn from this in thinking about how to proceed in the future? And just a couple of the lessons I think stand out for me. Firstly, I think that it's just very critical to keep in mind the very limited amount of resources, even with additional new spending goals, that India actually makes available for public sector health programs. Today, that amounts to something like an average per capita spending across Indian states of about 1,200 rupees, that's about 20 US dollars, of which half of which goes approximately to basic health care. So something in the order of 11 US dollars for primary health care. And that's just not a lot of money to pay for health. So what that means is, even if you're going to increase that money, if you're going to double that money, you're still going to have very clear priorities. And they need to be priorities that are feasible to implement and financeable. I think NHM, NRHM actually had such priorities, but they gave way to attention to other priorities, especially the need for health insurance for financial risk protection. And so this is a fundamental challenge for health policy in the future. How can India balance the need for health improvement with the need for financial risk protection and reducing impoverishing health expenditures? And also now, what about non-health service investments? What about sanitation? What about other things to improve behavior related to non-communicable diseases and so on? One example of a country that has much more resources to spend on health than India is Mexico, which launched a public financing scheme for health called Seguro Popular and faced this challenge of financial protection and basic health. And one thing they did in Seguro Popular is they put aside a special fund for financing high-cost interventions for the poor. So Seguro Popular finances a basic package of health services, but there's a special fund allocated for very high-cost interventions for the poor. And there's not a particularly brilliant rationale for this other than to say that it's a recognition of the need for both basic health improving interventions and also financial protection and some balancing of these things, but limiting the scope of both. I think that the experience of the last decade shows that both center and state financing are needed to substantially increase public spending, and particularly the states are going to have to spend much more if we're going to see a substantial increase in public spending. On expenditure acceleration and equity, the states with the weaker governance are certainly the lagging states when it comes to spending more or being able to improve equity. I'm not sure what we can do about that. It is very difficult to improve the fundamental governance conditions in some of these states. I don't think it's something the central government can particularly do effectively unless it finds ways to go around the causes of the poor performance of governance in those states. Monitoring and evaluation. I think this was a tremendous missed opportunity over the last decade. The main monitoring mechanism for the National Health Mission has been periodic missions or visits to states to sort of observe the process of implementation. almost no impact evaluation was done of different interventions under the National Health Mission. And I think this is a really important missed learning opportunity. So it's difficult to learn from what works and doesn't work, and it's difficult to know what to expand and what to contract. I think the National Health Mission experience emphasizes the notion that service delivery strategies need to be tailored to subnational conditions. You can't have common norms for staffing health facilities when states differ so dramatically in the types and numbers of human resources they have available. Some states which don't have very many more highly trained human resources need to substitute lower trained human resources for those people in order to make health facilities work and health services be delivered. So I think this is, again, an argument for moving away from national standards and moving more to state-specific standards and strategy. If states are going to play a greater role in mobilizing resources, and if states are going to develop their own strategies, states need to have capacity for policy and planning. I've been working in India since the mid-1980s, and I am still quite shocked that health departments in India do not have policy or strategy or really serious planning departments. It seems amazing to me that this function doesn't really exist in the structure of health departments at union or at state level in a serious way. How can a health ministry be seen as a policy leader or a steward for the health system if it doesn't have these capacities? And finally, and I think very important, is this issue of the private sector role. There's increasing lip service to the importance of government working with the private sector, but government has almost no experience in doing this effectively. How to analyze the potential of the private sector, write contracts, monitor contracts, and implement these kinds of collaborations is something that has been done in a very limited way in government. There actually are some very interesting examples. The most striking one is probably the National AIDS Control Program, which implemented most of its non-clinical services through contracts with NGOs. But that has been a separate body from the health department, and it hasn't really, that experience hasn't filtered very much into what the health department does. So those are some ideas about things for the future. Thank you.